Good morning, and thank you. And I would like to express my gratitude on behalf of myself and my colleagues to the National Cancer Institute of Azerbaijan, to the sponsors, particularly Roche, for this invitation. For some of us, it's going to be the first time that we are here in this beautiful country. We arrived to the hotel around 3 a.m. this morning. We don't have too much time to know, but at least what we're able to see in the horizon is very nice. After Dr. Banu's presentation about breast cancer, so I have to come to terms to the history, a little bit of history of pediatric oncology, and in a way is related to the history of humanity and related to the history of cancer development. Because in one particular moment, I always joke with my patients when they ask me, could you tell me a little bit about the history of this disease that my son has? And I always start, do you want me to start from close or a little further? Because I can start further, and I can tell you that in the beginning, everything was dark. And suddenly, light was made. So usually they select, you can come a little closer in terms of the history. And that is what the thing that happened for us. Many things, the medical decisions, they were based in what we see, in what we notice, in what we were able to evaluate. And around 500 years came the development of the microscope. And that is a powerful tool that the humanity has been used, and we are still using. We had 500 years of this development, and we are still using. It's quite useful, it's quite representative, but in some point, there are things that probably with the time we had to overcome. But let me go a little bit about part of the history of the pediatric oncology is related to the history of some diseases. And I would like to mention about Rudolf Virchow. He is considered the father of the leukemia research. He was the person to introduce the terms of the word leukemia and differentiate from leukocytosis. As a matter of fact, the first description that he did about this leukemia, he differentiated two different diseases, one coming from the splenic area and another coming from the lymph nodes, particularly when the lymph nodes, there were appearance in peripheral blood. He proposed the theory of the cellular origins of leukemia. And what the cellular origin of leukemia means, what was the theory that he started to propose in 1845? That a cell depends on another cell to produce cancer. And so far, that has been the dogma that we have been using for hundreds of years so far in terms of cancer research. We can go a little bit as well with the history of the chronic myelogenous leukemia, and actually that was described by Bennett, and he described this case 1 or 2 years before that Virchow, which is interesting. So in this moment, we are in 1845, and there was a lot of interest for the physicians to describe these are the diseases that may be important. But it's interesting, some of you may not be aware that Sir A.C. Doyle was actually interested in leukemias and the use of arsenic. And arsenic was one of the first elements that was used to treat cancer. The main problem is that at the same time that was used to treat cancer, and actually the first description of cancer cure by a medication was for arsenic, unfortunately, arsenic was used for different purposes and at different doses. Therefore, in the community was not widely accepted to the use. And suddenly, in 1876, came the discovery of two things. Came the discovery of the telephone, and also came this particular picture that was made by Sir Lux Fields. And what you can see is a physician seeing a pediatric patient. There is no bed. There is only 2 seats in which the pediatric patient is there. And I am not sure if you are able to see the father around here at the back. But that was the way that medicine was done, and still medicine is doing. How the physician is able to think, to consider about each particular patient problem, and how consider to solve that particular problem. When they were talking about the telephone, actually there was this editorial in Lancet, because what is interesting is that once the telephone was made and the people start to see this particular picture, there were consideration in 1876, okay, now is going to occur that people is going to be using the telephone to call to see a physician. And this particular patient has to be there waiting for the physician to answer. There were criticisms about how the technology was used in terms of in terms of the medical field. The development came a little further because in some point the people was trying to develop some chemotherapy agents in order to treat cancer. Cancer was a devastating disease. Around 1945, 1947, there was an interesting observation from Sidney Farber. They were seeing a lot of deficiency of vitamins in pediatric cases, and they were trying to analyze this in mice. Well, it turns out that some of the mice, they were having leukemia. They were part of the observation in the laboratory, and they were using folic acid to see what happened with the disease. Well, it turns out that the mice, they died rapidly, and the critical observation that they were able to do is that the mice developed the leukemia and progressed faster in the presence of folic acid. Therefore, at that particular moment, the concept, if we are using something that is able to improve or increase the progression of a disease, what about if we use something that antagonizes this? At the same time, close to his lab, there were the development of an antifolate medication called 4-aminoterglutamic acid, also known as aminopterin. So the concept was, if we are using elements that increase the cancer progression, let's use aminopterin to see what happens. And it turns out that in the moment that they start to use aminopterin, the mice, they start to improve. So they decided to use very quickly in pediatric patients, and actually that was considered the first time that a human cancer was cured by the chemotherapy agent. Because what induced this aminopterin was partial remissions, but the patient was able to live for several weeks, including several months. What is interesting is that, at least based on that, that was considered the moment that the specific treatment for acute leukemia just started. However, the changes in pediatric oncology, similar to the changes in any oncology field, in any cancer field, are always found resistance to be accepted. And that resistance to be accepted is based in different considerations. So in that time, the consideration was that the antifolates and antipurine drugs, after they were introduced, many hematologists and many pediatricians, they refused to prescribe because they were too toxic for the patients. Indeed, they were. They had reason. They were too toxic for the patients, because we didn't have too much time to learn about how to control this toxicity. And this is something that Banu mentioned to you. In the moment that we start trying to do different medications, what we have to do is to learn how we can do better with each particular medication. In the 1970s, parents, they were advised, and medical students, they were taught that they shouldn't use chemotherapy to treat leukemia in childhood, and they should let the patients die in peace. That was the general concept. What about if humans challenge that particular concept? At that time, in 1954, MD Anderson was created, and many other institutions that were created. And we were quite lucky to have the opportunity to be with Dr. Wataru Suto. He's a Japanese descendant. And in 1954, he came to MD Anderson to help to build the pediatric unit. He was honored to be the first physician to introduce vincristine, the chemotherapy called vincristine that we commonly use in the treatment of Wilms tumor. And as a matter of fact, he was one of the creators of the National Wilms Tumor Study. In this moment, there are a tremendous progression in that, and you will see what happened with Wilms tumor improvements in the treatment. He introduced the treatment for osteosarcoma, and actually he was one of the editors of the first pediatric oncology book. Also, as a matter of fact, he was dedicated to other things, and one of the studies was in Seychelles. But I would like to work a little bit in this concept from Wilms tumor, which is a renal tumor for those of you that are familiar. And I would like to see, and I would like to show you and to see what Dr. Giulio D'Angio, a radiotherapist from Philadelphia, was talking about that. Because in 1950, the survival, the death for Wilms tumor was close to 100%. But actually through the time, in 75 years, that was reduced to almost 10%. A human cancer has been changed, the death rate from 90% to 10% in 75 years. So he was presenting this conference in a big meeting, and suddenly the people, he was presenting as a great advance. And the people and some of the observers say, I don't think so that it's a great advance, because you have taken 75 years to improve 90% survival in the patients. And he replied with this. And in this moment, we are talking about 1985. And he replies to this, and I would like to reduce all this in terms of improve the translation. And he said, well, I disagree with you, because if we take the history of the humanity and compare in a 24 hours, we realize that at midnight, every human with cancer died. And so on and so on and so on until we reach 11:45 p.m. At 11:45 p.m., the first human being with cancer was saved. At 60 seconds later, 5% of the humans with cancer survived. At 11:47, 15% survived. 4 minutes more, and 45% of humans survive. Another 4 minutes, and 80% of the kids are cured. And in this moment, we are 11:59. The only difference is that after midnight will come another day. And we and you will have the opportunity to see the new light. And actually, one of the things that we would like to share and work together is precisely for many of you, the young people, the young generation, to be able to follow these steps and to get to the new day. By the same time, in the 60s, 70s, was created another hospital, St. Jude Children's Research Hospital. And actually, Donald Pinkel was the first director, and actually he was the person to lead the leukemia efforts. So he introduced a concept that was quite interesting, the concept of total therapy. And this concept of total therapy was relatively new in terms of cancer treatment, because the concept was we need to use different chemotherapy agents at the same time, number one. And we need to use rotational chemotherapy in order to improve the survival of the kids. These two simple concepts, they were used in order to improve the treatment of leukemia patients. And in order to do that, you can see, and I will show you later where we are in terms of the leukemia. But you can see that in patients less than 20 years, all cancers start to increase a little bit in the incidence of them. And if you see this table, and I will walk you through this, we are seeing the survival of the kids 15 years of age or less from 75 to 2005. And you can see that the all sites starting in 58%, the survival is close to 81%. For some of the tumor, there have been quite dramatical improvement, for example, in acute lymphoblastic leukemia. In this moment, is here 89%, but the reality is that we are reaching close to 92, 93%. Acute myeloblastic leukemia, we are still in the 50s, 60%. Hodgkin lymphoma, we are reaching 90%. Wilms tumors, where Dr. Sataro work, is in the 90% as well. And that has been this improvement through the time and through the use of the trials. But in a concept view, how we reach that? Well, what the keys of success? The keys of success have been relatively simple. Difficult to accomplish, but they are relatively simple. One, improve the patient access to clinical trials. In the United States, more than 80% of the pediatric patients, less than 18, they are enrolled in trials. If you compare that with the adult population, that they are less than 10%, that made a huge difference. The second, the opportunity to use multi-institutional clinical trials consortium. In this moment, the Association of the Children's Oncology Group is more than 240 hospitals that work together. In Europe, you have different associations. You have the Berlin Frankfurt Munster group, which is very good in what they are doing. You have the Italian groups. They are very good. You have the Nordic Oncology and Pediatric Oncology Organization. They are very good. And this is the concept that in general we are trying to work. We don't work alone. We work in a community. The pediatric oncology is a relatively small community, and working together we do better. The concept of the use of multi-drugs and rotational combinations, the design of treatment that maintain or improve the cure rate and reduce secondary effects. And this is the hallmark of where we are in this moment. We know that in many diseases we are getting a good cure rate. Now the concept, how we can improve for some of the high-risk patients, but also for those that they have relatively less difficult to treat disease, how we can minimize the side effects. Why? Because the side effects are important for us. When Hodgkin lymphoma patients, they were treated 40 years ago, in this moment we know, 40 years later, that more than 50% of the females that receive chemotherapy and radiation, they have developed breast cancer. And we have to deal with that, and we have to improve that. We have to advocate for the access to new medications or treatment options. Derek already mentioned about the coordination to do registers. I think that's important. And also to have the concept of a global health approach to the problem. I agree with what he mentioned before in his previous conference. We are reaching the point where in some countries we can cure 92% of acute lymphoblastic leukemia, but in other countries it's less than 25%. So how we can improve the gap? And one of the ways to improve the gap is to analyze some of the current events. And I would like just to bring this information because this is something that is critical for us, is the adolescent and young adult population. What is the adolescent and young population? It's a population that they are between 15 to 30 years of age. And what you can see here in different diseases, the survival in this particular population has reduced dramatically. It doesn't matter what we were doing. Therefore, we need to improve that. Also, if we look how the work is looking, all ages, patients that they are more than 30 years, and patients that they are the 15 or 29, adolescents and young adults, or they are pediatric patients, we can see that in low-income countries, the mortality is very high compared with the rest of the world. In lower middle incomes, it's improved, but in high-income countries, the mortality has reduced. Therefore, there is a tremendous effort, tremendous task that we need to do in order to improve the health of many pediatric patients. But actually, part of the discoveries of this has been not only in the concept of epidemiology registers, but also in the area of molecular analysis. And I think that the feature of Watson and Crick described tremendously many of the things that we are doing right now. And I would like to introduce one of the concepts and one of the movies that has been interesting, and I don't know if many of you are aware. Star Trek was a movie in 1966 about science fiction and people that travel around the universe with the concept, and this is quite interesting, the concept is looking the frontier. What is the frontier of our knowledge? And that is interesting because in 1966, you can see all the gadgets that they were using, and actually this is what we are using right now. We were using this kind of telephone, we were using this kind of tablets. This is our daily life. What in one moment was just future, was science fiction, was the concept of how to use the telephone to request an appointment. In this moment, this is daily life. The only thing that we have not been able to do is what happened here. At some point, we may reach that. The fact that we were able to know a little more about genetics, about DNA, has been introducing the concept of target therapy, something that is specifically directed to a molecular abnormality or changes. And the hallmark of that has been the analysis of the chronic myelogenous leukemia. You can see here, for example, the molecules and actually how imatinib and dasatinib interact in the loop of the tyrosine kinase and the interaction with the different amino acids that made the susceptibility of one of these agents 300 more acceptable to that particular push than the others. But that target therapy has been able to be used to treat one of the diseases that at some point they were considered untreatable. Everything that has been associated with BCR-ABL, either as a chronic myelogenous leukemia or as a leukemia. But at the same time, this target therapy has allowed the development of new medications. But one of the things that we are understanding for these medications is that they are not coming alone. Despite that they are developed for a specific target therapy, it turns out that the interactions are a little more complex. And what you can see here for dasatinib, this is the dasatinib push. What you can see here is how affect a tremendous amount of other tyrosine kinases, how imatinib affect, and how the new tyrosine kinase inhibitor, they are able to overlap the things. And that is important. That is important because when in pediatrics we have chronic myelogenous leukemia, in kids that they are 2, 3, 4, or 5 years of age, there are tremendous effects that they are associated with that, and we are learning how to deal with that. Now, the point is, with all this advance in molecular development, what are we going to do? Every time we receive information that there is a new medication, there is a new approach. So in some point, maybe a little confusing because actually we are coming into the era of how genomics is going to manage or drive the cancer medicine. That is where we are in this particular moment. And actually, relatively simple, the concept. We take a patient encounter. There is a lot of information about that. The analysis about disease, analysis about possibility of relapse, get a fresh biopsy of fresh tissue, do the analysis of this fresh tissue, and start to get a lot of information. But the question is how we do this data interpretation of the different omic profiling, proteomics, genomics, metabolomics, etc. So we have to get to the point that we have to get a managed decision. We have to take a clinical decision how we are going to do, what will be the best way that we are going to treat this patient. And actually, later on, we have to assess what will be the clinical response. Because since in one particular moment, the patient starts to develop drug resistance, we can use tissue and start to analyze why is the resistance and how we can overcome the resistance using all the information and the previous information that has been done. Looks relatively simple in the paper. However, in real life, it's a little more complex. When we are able to analyze for some of the tissues in some leukemias, the same patient at the moment of diagnosis and later at the moment of relapse, there have been too many genetic changes that sometimes they use different metabolic pathways and different ways to escape to the treatment. In that way, there is a different model that has been developed, and this is what we are going to use. And probably the young people that they are in the audience, that's what they are going to use. The use of get the patient here, telehealth, use phenomena, use social media. Through social media, through your telephone now, you have the opportunity to get your medical records and to get communication with your physician. You are able to get appointment, you are able to get your labs, you are able to get information about your medication and when the medication has been placed into the pharmacy. We have epigenomics, transcriptomics. We have analysis, opportunity to see information about multiple cells or single cells, how we can use genomes, proteomes, and to do a translational education. Because at this moment, the future is coming to the point that whenever that happens, and I don't know if you are able to see, hopefully, probably no, but I apologize for that, is when, let's say, we take the history of the patient, we put through times. This is the moment that the patient has developed one infection. This is the moment where the patient develops another infection, respiratory syncytial viral. This has been the history of this patient, the method, the analysis that has been used. This is the integration of the personal omics for the patient, and that's the way that the new information may come in some time in the future to us. Where are all the changes at the level of the RNA edits, the levels of changes in single nucleotide points, the levels of proteins are down-regulated and proteins are up-regulated, how the RNA is down-regulated and is up-regulated, and how the chromosomes are changes and the chromatin histone interactions are changes, because they are important. The question for us is, are we ready as a physician to receive this kind of information and to work with this information? The answer is not. We are not ready. We are not ready just to receive this information, and this is your patient, this is what is the patient that you are going to see in the next 5 minutes. This is the data that you have to analyze, because we don't have the tools to take all this information and to put in a way that will be clinical representative to us. And that is what the future is coming, how we can deal with that. And that is going to be a new way to see the patients, because at the end of the day, that is our job, see the patients. I appreciate that you went with me in this journey through the time. And what I mentioned to you is that taking the patients and going to the point of technology, there's a lot of technology and a lot of informatics-based resources that they are going to come into clinical practice. But at the end of the day, when you look the eyes of the patient, when you look the eyes of the father or the mother, you realize that they are human beings, and we have to act as a human beings. Thank you.